I think, Eman, if you agree, we can start with you introducing our guest today,
Sure.
and then we can start the lesson.
Okay. So again, good day, everyone, and welcome to a new DCB Academy session. It is a real pleasure again to welcome Dr. Mohamad Alkhouli, an interventional cardiologist at Mayo Clinic, widely recognized for his contribution to structural heart disease intervention, complex coronary disease, and outcome-driven cardiovascular research. Today, Dr. Alkhouli will be sharing his perspective on cardiovascular innovation and precision medicine, and whether emerging deep technologies truly have the potential to bridge the gap between innovation and meaningful clinical impact. Dr. Alkhouli, thank you again for being with us. We are very much looking forward for your talk. The stage is yours.
Thank you.
Awesome. Thank you all very much. It's my pleasure. It's really an honor to be with you today. So the topic innovation is a very hot topic, as you know, especially in cardiovascular medicine. What we want to address within that broad topic today is there a gap in the innovation? Is there a problem with the precision approach that we're taking, and will emerging technologies help us address those gaps? Really no major disclaimers that are relevant to the content of this talk, but there will be a little bit of philosophy and big picture concepts that we will discuss. We won't just be discussing studies and specific technologies. We would like to zoom out and look at the big picture, sort of to recalibrate our thinking about the field. We will try to focus on some of the emerging technologies. I do have to acknowledge that I will leave the agenetic AI out of this talk just because it's a very broad topic, so that will not be covered within this context. So let's just recalibrate for everyone here. The main question we're trying to address is, can emerging technologies be used to achieve precision in cardiovascular intervention? So let's dissect that question a little bit further. First, we have to define what precision medicine is. We have to then question, do we mean that we're really not very precise now, or do we just want to get better? And if the former is the answer, then why is that the case? And then we will position the new technologies in that sense after we do go over some definitions, so we're all on the same page. As you know, we like big, lofty names, but essentially, we can simplify the terminology we're using into what it exactly means. So when we say precision medicine, it essentially means delivering the right treatment for the right patient at the right time. So essentially, just being a good doctor is what precision medicine is. Now, it has obviously nuances and other things, but the fundamental concept is just to do what we have studied all these years to do. And why it matters, let's just go over the landscape of innovation that has happened in cardiovascular medicine over the last 75 years. From the first open heart procedure till today, we have had many devices, many new procedures and interventions introduced, leading to essentially a halving of cardiovascular mortality over time, as you can see in this graph here. And on the right side, you see many more emerging technologies that we haven't seen the fruits of yet, but we started to see how those would also impact the field. So this is counterintuitive to the intro that I gave earlier. Does that mean, if we're making that much impact, how can we claim then that we're lacking precision in our approach? And I'll tell you exactly what I mean. You may be familiar with this concept called the health span versus lifespan gap. Essentially, mortality has been reduced substantially worldwide. It's plateauing in more recent years, but especially in Western countries, the mortality has reduced. Yet the last few years of people alive isn't as rosy as we had promised them to be. So this is what we have told patients: you're gonna live longer and be great. And the reality is they're living longer. They have devices and they've gone through a lot of interventions, but it's not as rosy as you might think, leading to disappointment, massive costs, and just inefficiency in the system. What some of the procedures we're very proud of, like TAVR and edge-to-edge repair, some of you practice, have some interesting data. This is from the NCDR registry. And regardless, I mean, these are papers looking at the impact of residual TR, tricuspid regurgitation, on outcomes. But that's just a variable. Look at the big picture here. With TAVR, roughly 50 to 60% of patients are alive and well at 1 year. By that, I mean they are alive and they have seen an improvement in their health status. Only 50 to 60% with the best procedure we have in our field, which is TAVR, as you know. The picture is even more grim with edge-to-edge repair. That ratio goes down to 40 to 50%. So if I tell you now that all of these great technologies that we're implementing in the cath lab are only helping half of the patients at 1 year, you would be skeptical and you say, no, that's not what we really see, but this is the data. And this is over 130,000 patients with TAVR, 20,000 patients with edge-to-edge repair with a purpose-specific database registry in the US. Also, the cost of all of those innovations that we are producing is unsustainable, given then that a lot of innovation starts in the US because that's where a lot of the capitalization of the benefits, the economic benefits of innovation will be recouped. You can see here that the health expenses at the bottom, and you can see on the y-axis the life expectancy. If you chart how much we're spending to how much benefit we're getting from innovation, you would definitely conclude that this is not a sustainable pathway. So there is a gap. There are innovations that are costly, not as fruitful as we have thought they would be, and they are not sustainable. So let's try to speculate some reasons why would this gap exist, right? And this is just my claims. We can argue at the end. We can discuss that. I could be wrong, definitely. But looking at the innovation gap and trying to understand why are we there, came up with these few potential explanations. Number one is, in general, our research treats people as populations, not as individual, right? And the human physiology, pathophysiology is so unique that it is nearly impossible to understand the individual. And because of that, we reduced the science to a way that we just look at people in average, in aggregate. We say if 1 million people got this intervention versus that, on average, those other million will do better than the first million, something like that. But for the individual patient who you are responsible to treat when they come to your clinic or to your lab, you're putting that glass of the average and you're looking at people as averages, even though they are not averages. They're very distinct. This is an example here with an oral anticoagulation with atrial fibrillation. We all know that AFib is becoming a global pandemic. It's more prevalent in the Western Hemisphere. But let's just take that example. Over 50 million people currently are known to have atrial fibrillation worldwide, and we recommend almost all of them to be on a blood thinner based on what? Based on a risk stratification tool, the CHA2DS2-VASc score, that is extremely oversimplified and extremely inaccurate. In this meta-analysis, we have shown that the predictive value of CHA2DS2-VASc score in predicting stroke in high-risk patient is very, very modest. It's 0.67, so 0.5 is a flip of a coin. We're closer to a flip of a coin than to a perfect prediction. And the more important aspect of the study is that there was no difference between patients who had atrial fibrillation or not, essentially telling you that this weak inaccurate score is a vascular risk score. It doesn't really have much to do with atrial fibrillation, yet it's almost embedded in the guidelines and in our practice as the Bible of how we treat AFib patients, right? Again, emphasizing this problem with looking at people in a population sense, and we would only accept weak scores, inaccurate scores, if we're looking at populations. If we're looking for individuals, we wouldn't accept this much of crudeness in the predictive value. This is another example, as we say that the appendage is a big source of thrombus in patients with atrial fibrillation. And these appendages, as now we do left atrial appendage closure, so we know how they're extremely variable in size, shape, and function, yet the CHA2DS2-VASc score is completely oblivious to the shape of the appendage, to the size of the appendage, whether it's a small, highly contractile structure, or whether it's a big, baggy, angry structure like this on the bottom right. It treats them the same. If you had 10 minutes of atrial fibrillation or 20 years of atrial fibrillation, CHA2DS2-VASc score does not really know that. It's all the same. But we know that doesn't make any sense. We just find it hard to question the dogma of these risk scores that are based on population that we have to use just for simplicity. So we have traded simplicity with accuracy over the time in our practice. Another thing is the partiality of our view. Let's just stick with this same example of left atrial appendage and the atrial fibrillation. If you ask 100 of your students, what does the left atrial appendage do? What would they tell you? It's a source of thrombus, right? Nobody would actually think, or maybe a few people would think, well, it's there for a reason. It has function, right? But we have equated it with stroke because we have this partial view that we're focusing on stroke and we're trying to find a solution, trying to come up with devices and tools. So we have skipped completely that this appendage actually is a very unique structure. It has hemodynamic function. It has a big role in atrial arrhythmias. It affects hormonal regulation, and it's one of the largest stem cell reservoir in the body, right? But that all goes to the shadow because we have this partial view of a structure that this is a source of thrombus, and we should just close it. Indeed, at one conference, there was a debate that every single human should get their appendage closed prophylactically, and that was a serious debate. It was not honestly a joke. It's like everybody or almost everybody is at risk of atrial fibrillation as they grow, and let's just prophylactically close the appendage of everybody. So again, emphasizing how we're viewing things in a partial sense, not in a holistic fashion. Our solutions also often don't match the problem we're trying to solve from the anatomy standpoint. Same example with left atrial appendage. For many years, we were told that leaks, we can't really close the appendage perfectly because it's extremely variable. Most of the time, we leave small leaks behind. We have small studies at the beginning. They were randomized, but they said that the leak doesn't matter. And that's what went for 10 plus years, that leaks don't matter, until we started publishing more newer studies with larger populations, seeing that even small leaks over time, they actually may double your chance of ischemic event. Again, emphasizing how our solutions don't perfectly match the anatomy, and even more is more significant is the example of mitral valve interventions that we're trying to now propagate. So look at the function of a native mitral valve, how beautiful the structure is, and how when we try to replace this apparatus with our TMVRs, we are not even close to mimicking this kind of anatomy. Indeed, a lot of the surgical and now the transcatheter valves, not only they replace this beautiful apparatus with the tri-leaflet valve that's not meant to be in that place, but it also places the valve at an angle where the fluid dynamics of the heart completely get altered in a negative way. Indeed, there are some studies showing that you lose up to 40% of the energy, or you add 40% more energy requirement when you replace the valve to the heart kinetics because of this mismatch in the vortices and the flow that happen after you replace the valve. Yet we don't think about that because the hype or the interest is we need transcatheter solutions, we need more valve interventions, but do the valves actually or our interventions match the native physiology or not? That question goes to the shadow again. Another reason why I think we're imprecise is I believe that in the innovation ecosystem, the scientists take a back seat. They're not really the ones who are taking a big role in deciding how the innovation landscape goes, or what should be prioritized, or where should we invest our time and resources. Take the example of the tricuspid valve. The tricuspid valve we were told to forget it for many, many, many years, right? Until we were told not to forget it anymore, because now there is interest from industry, who essentially usually is in the driver's seat of running innovation, there is a reimbursement code for TAVR, there's reimbursement code for TMVR now, or TEER, and there will be a reimbursement code, or most recently there has been a reimbursement code for tricuspid. So we should focus. There is an opportunity here. And then we started seeing publications like this one in 2021 showing us that in maybe 30% plus of patients, the tricuspid valve is not tricuspid, it is actually quadricuspid, or it has multiple cusps, more than what we think. Well, it turned out that this exact study was done in 1971, but we didn't pay attention to it, or we didn't even cite it in this paper because at that time nobody cared about the tricuspid valve, and now we are sort of in a passive way, almost like an end user fashion, are drawn into doing more and more tricuspid research. And if you think about how we evolved our aortic and mitral interventions, we had good understanding of the disease, especially with the aortic, and we had good treatment in the surgical form. And now we wanted to do less invasive stuff. With the tricuspid, we flipped the progression completely. Our interest started, we need the transcatheter solution. We don't understand surgical outcomes. We don't understand what causes TR. We don't understand the national progression. And we don't really know what's the optimal time of intervention, right? And that's now getting reflected in the tricuspid trials where the results are not as excellent or shiny as we had expected initially, right? Because again, we didn't start from the scientific or clinical unmet need. We started with a technology push rather than a need pull, right? There's another reason why I think we have a problem with the precision in our interventions. Lastly, we have some dogmas that we just don't question. Doctors are very good at not questioning things. Let's look at the example of echocardiographic assessment of tricuspid regurgitation and mitral regurgitation. So in this case, whenever you guys do tricuspid mitral edge-to-edge repair, you will ask your echocardiographer, do we have, is this adequate or not? And we completely focus on the color, right? This is the color dogma. Look at after the first clip, we had this amount of color in this second clip here. and the echocardiographer suggested that we keep going with more clips because we haven't really done much. There's still moderate plus MR, but we had left atrial pressure being simultaneously recorded here, and you can see that the left atrial pressure normalized after the first clip. But because we have this dogma of color, we went ahead and put a second clip. It didn't make a difference. Indeed, there was a little bit more color. The LA pressure didn't change at all, right? But we skip other source of information that we have because, again, we focus on one area. Color has been around for a long time. Everybody believe in it, but we do see the left atrial pressure normalized. Patients feel the pressure, right? They don't see the color. Yet we seem to focus on one area that has been the dogmatic for a long time. We did a 4D MRI study here at Mayo, 52 prospective cases, where we looked at multiple 4D color, 4D, not just color, 4D flow CMR parameters to estimate the degree of tricuspid regurgitation. And those are all patients who had at least moderate TR. On echocardiography, it turned out that echo overestimates tricuspid regurgitation in 68% of the patients, right? So we call it severe, but when we did MRI, it wasn't really severe in many patients. You could argue that, well, maybe MRI underestimated the TR, but how do we know? How do we know which one is accurate unless we do a longer study, larger study, and we benchmark it against outcomes? This is to be done, but again, just trying to challenge the, conventional wisdom that you just see color and you just call it severe. We don't know. We need to incorporate all of these newer technologies that we have to arrive at a more solid, precise estimation. Okay, so now where we're at now, we have talked about the innovation gap. We have shown that we're not as precise or as sustainable as we would like to be. And we speculated or we shared some reasons why we think this innovation gap exists. So now we have new technologies. We're not anti-technology. We're very excited about technologies indeed. So how do we implement the technology in a way that is useful and that would help us bridge this gap and become more precise? Before we go into the second section, which is the solution, does anybody have questions or should we keep going?
I think we should keep going. Yeah.
Okay. You still see the screen, correct? Okay. All right. So I have to admit that I was one of the early skeptics of AI, because I had believed for a long time that what we're missing is actually the deeper human analytical part in medicine, not more technologies. But I have evolved, and I will share with you now how I think AI will help us augment our capabilities and fix this gap. Has any of you taken a ride in a Waymo or in a driverless car?
Not yet.
Okay.
Not
If
yet.
you go to California or Seattle, feel free to try out the Waymo. It's an interesting experience. Being a skeptic, I had to read the studies that they have done about safety before I took my first ride. But this is the reality. So this is how the car works, and this is what it sees. This is on the left side, you see how many cameras are embedded in the car, and the accuracy and the massive amount of data that it is able to process moment by moment. So that's why I started thinking, even if humans are the smartest people ever, they won't really have this many eyes and this huge brain to analyze all of this data simultaneously. That could explain why the Waymo car resulted, when they compared it in the randomized fashion with regular taxis, it had less accidents overall, because not because it is smarter, but because it has an unbelievable processing ability in that massive computer, and it has an enormous sensory capability as well that we just can't have. We have two eyes. When we drive, we can barely see in a maybe 180 degrees maximum, and we're distracted and thinking about a lot of other things, right? So I did see that that's where the value of AI can come to augment our sensories and to increase the processing power of our brain. So let's get a little bit more specific. We'll share with you a couple examples in the coronary and the structural space. So coronary angiography, I don't know, you may have this technology in your labs now, but we typically use wires and imaging catheters to do intravascular ultrasound or get physiology numbers. But those seem to be now uh, with reasonable accuracy, amenable to be derived from just bare angiographic images without the need for additional instrumentations, additional heparin, and all of that. So wire-free FFR is becoming more and more standard in a lot of labs worldwide. Same thing with imaging. You can get precise sizing now, almost like an OCT level sizing of the vessel with device-free measurement using both a mix of computational dynamic assessments as well as AI. And if you look at the diagnostic performance of those combined devices, if you want to take both anatomy and physiology, you're getting in the above 80, almost above 90% performance range now, which is fairly good, and it can help us be more efficient and less risky when we do our interventions. So we are experimenting those technologies in our labs now, but this is one additional angle that I thought AI can help us in the cath lab. Remember, those technologies are looking at the lumen of the artery and trying to derive extra information based on AI and computational fluid dynamic assessments. But the image that we take in the cath lab has more than the coronary artery, right? Even the coronary artery is embedded in a muscle that is moving, and we take multiple views in multiple dimensions. So can we see more, right? We looked at the trees with the FFR and OCT technologies, or device-free OCT and IFR, FFR technologies. But let's see if we can see something more. So let's do this exercise together. At first glance, if I ask you, give me a diagnosis, or describe those angiograms, you will tell me that the one on the left side is normal. The one on the right side has a spontaneous dissection in the mid to distal LAD. And the one on the right side looks good. There is a patent stent at the proximal LAD that looks properly sized and has no restenosis, right? So that's what we would say when we look at this image. But let's take another look now. What else do you see? For the sake of time, I will cheat and give you the answer, but just think about it for a second. What else do you see on these angiograms? You see what you saw earlier, but you also see severe MAC on the left image. You see undigested pills in the middle image. And you also see anterior wall motion abnormality on this last image, because as we said, the arteries are embedded in the wall, and the displacement of the artery with motion should be a surrogate to how the heart function is, or the systolic function is doing. So So we wanted to add to what everybody else is doing with their IFR, FFR, OCT. There are tons of studies, lots of technologies. We got a few smart people from different parts of the world to come help us on this project. It's called the AI Encode Study. We have almost over 20,000 labeled angiograms from Mayo. And we first did some quality assurance to make sure that the AI algorithm wouldn't misdetect, for example, a pigtail catheter or pacemaker wire or something. You know, if you have inadequate filling of the arteries, we don't want the AI to misinterpret or overread these angiograms. So after we did the quality, we started thinking, what can you intuitively derive from the angiogram? This is very, very important. If you want to take home one thing from the question that asks, what can AI do? My suggestion is think about it in the following manner. If it's a task that human can possibly do, a smart, experienced human can possibly do, but it will take a lot of time and effort, then AI is perfect for it. If it's a question that humans cannot ever answer, even if you bring 100 brains and a lot of eyes to them, then AI will not be much better. So think about this example. We have the angiogram, we have the arteries, moving in different directions. What would be intuitive things that you can get from that information? You could see the regional wall motion abnormalities, right? You may be able to derive a cardiac output. You may be able to estimate filling pressures from how stiff the heart is, or how much edema is in the wall. Is it moving as much or not? So you can estimate that. You could estimate RV function, systolic function as well. You may be able also to tell something about the pericardium, because you can see calcifications, you can see the artery is almost stuck and not moving as much in constriction, right? But at the same time, you can't really tell the patient. There are less intuitive things, right? You can't tell if the patient is having depression looking at this angiogram, right? So you have to go with a task that humans can possibly do and see how AI would help you be more accurate and quicker. So we developed algorithms for all of those following things: LVEF, filling pressure, cardiac output, RV function, and constriction. 3 of those algorithms have been published. 2 are in press or in revisions. The first one is looking at LV ejection fraction against the gold standard of echocardiogram. And we got an AUC in the 0.87 range for a binary prediction of less than 40%, more than 40%. That can be helpful if you're doing a STEMI in the middle of the night and you see, you get this, you don't have to do anything. As you're doing your angiogram, the machine will spit out a value telling you that this patient has reduced ejection fraction, so it will help you tailor your intervention and potential support. Same thing, we got really good prediction in estimating LV filling pressure and diastolic filling pressure. We got good prediction in estimating RV function. So again, you have a patient in shock. It will be helpful for you to know if the RV is down or not. In the middle of the night, you may not have access to stat echo, so that information is readily available. Same thing for cardiac index, cardiac output. This paper is currently under revision, and the gold standard here was a simultaneous right heart cath in several thousand patients, so really unique data set. Finally, interestingly, the best prediction we got is in predicting pericardial constriction. It's a very difficult diagnosis to make. We have a dedicated clinic at Mayo for that. Lots of those patients had tissue confirmation via biopsy or surgical stripping of the pericardium, and almost everybody had an MRI. So we leveraged this unique data set and we got an AUC of 0.96. Essentially, you're doing an angiogram in a community hospital, and the screen will tell you all of the prior data, ejection fraction, cardiac index, RV function, diastolic function, without you doing any additional view or any additional task. And then it will also hint to you that there may be some pericardial disease. So community hospital that may not have access to a tertiary uh, pericardial clinic will benefit from, referral of that patient when things are unclear. So that's what I meant. Lots of studies have looked at the trees, which were the coronary arteries, and we decided to take a wider look at the angiogram and see what else can we derive from the angiogram, and hence we had those technologies developed over time. Another example is aortic stenosis. How can AI, computational fluid dynamic, emerging technologies help us do better in managing aortic stenosis? And I'll show you how that can be in terms of first, rapid and accurate diagnosis. Another big task force that we had at Mayo is our ECG lab has leveraged their millions of ECGs that we have and also the massive data set of echocardiograms that we have. We do about 100,000 echoes a year at Mayo. So pairing the ECG and echo, we were able to get algorithms that will tell you if the patient is likely to have aortic stenosis with fairly high sensitivity, specificity, and AUC, as you can see on the bottom right. This is what we see now in EPIC. Every time somebody gets an ECG, we have a probability of aortic stenosis embedded in our EPIC or electronic medical system. And this is an example of a patient who had moderate AS, and as the aortic stenosis progressed, the ECG started showing these kind of LV strain and other features that we can't really tell in the individual patients, but because the AI has analyzed hundreds of thousands of ECGs, is able to tell us that this patient now is approaching severe aortic stenosis. Same thing, there's another research fellow we had from Taiwan who looked at all of our CT scans that we do for TAVR. As you know, one of the problems we alluded to earlier is the futility of intervention, where half of our patients are not doing well at 1 year. And we thought that some of this information can be predicted from just looking at the mass amount of data we have in our imaging. And we were able to derive frailty and improvement in symptoms just from looking at the CT scans. We look at the CT, there is maybe 100,000 data points in the CT scan, and we look at just a few, the size of the artery, the size of the valve to do our TAVR, and we sort of skip all of the other information that is highly relevant. So AI can help us with that. This is another very promising, interesting project that we did, which came from my interest in waveforms. These three waveforms on the left side, invasive waveforms, have similar pressure values, but they mean different things. The pressure is the same, mean pressure is the same, but you can see the contour, the shape, the upslope, downslope of the waveform is completely different. And we wanted to see if we can leverage those pattern recognitions using AI to make a diagnosis. So we looked at the cohort of 37,000+ patients who underwent coronary angiography, and they had invasive waveforms. And then we correlated those invasive waveform shapes, contours, phenotypes with aortic stenosis. And this is the interesting thing. Just looking at the waveform, we had an AUC of 0.95, predicting that this patient has moderate or more aortic stenosis. We don't know anything about the patient. We only have this waveform, and we can tell you with this level of accuracy that the patient has aortic stenosis, because aortic stenosis is a valve disease connected to a vascular disease, right? Connected to the aorta. So the aorta is exhibiting, or the interaction between the aorta and the valve is exhibiting some of that disease. And you can see that information in the waveform. but you would require somebody of the caliber of Dr. Nishimura or some, elite hemodynamist who can tell you this waveform means XYZ. We can't do it. And that's where AI can help. The even more interesting thing is when we had false positives, where the waveform told us that the patient has significant AS, but the echo shade wasn't showed that it wasn't as significant, yet those patients had higher mortality over time. Again, showing us that AI can help you look at things holistically, not really just at specific points. Maybe we can skip over this, but quickly, there are a lot of papers now that talk about coupling, decoupling, RV, PA, aorta, aortic valve, LV, all of that. And it's good to publish this kind of papers, but this is emphasizing or reiterating that we were looking at things in isolation, where who told us at the beginning that the valve is isolated from the ventricle or the large vessels,
Yeah,
right?
Mohammed, sorry to interrupt. I have to rush and go away. You disclosed as a universe, and so many topics, so many questions, and these are our the questions that the physician should ask him or herself. It was much easier to do our job like 20 or 30 or 50 years ago, okay? Because we only had to deal with a book or with books or with some novelties. So now we are bombarded by a lot of novelties, a lot of clinical trials, a lot of new ideas, and then all of the technology and what the technology is bringing us. And also ethically, we have a lot of questions that arise. For example, which will be our role as humans and also our role as physicians in not 50, but like 5 or 15 years from now. So this is really provoking and interesting what you said. So I really wish to thank you for all of these hints and all of these questions that you posed us. And unfortunately, we have only a few answers to all of them.
Yeah, thank you. Really appreciate it. Maybe as you go, maybe consider, I read a book recently called Reshuffle, and this book talks about how in the past the people had little access to technology, but they had a lot of human intuition and talent and analysis. Now it's the opposite. We're gonna get into an age where, the human capital or our mind capital is going to be the precious asset, which could level the competition worldwide for things. But lots of questions have to be answered.
Yeah, but I agree. And the difficult thing here is to maintain. And sorry, I'm talking. I'm sorry. Give me a second. So, so the big question that we have is which will be our role. So we have an important role. We have to maintain the control of everything, the technology, AI, and generative AI. All of them will have. For example, last week at Gym in Rome, we did for the first time, we organized a symposium where the AI, a generative AI, we gave it some angiographies and some CT scans and some intravascular imaging, and we asked them, according to these papers, okay, so according to these papers that we give you, please suggest us which is the best treatment, which is the best way we should prepare these lesions. And the last question was, now, after this lesion preparation, would you use a DCB or a stent? Okay, so very simple. Okay, so if you have the control of that, if you use your mindset and if you use it to educate physicians, it's fine. But if you completely rely on it, I think that so far it may be worrisome.
It is, yeah, very. No, thank you for the insights. I think much more to discuss. Hopefully sometime we can have that discussion in person.
Oh yeah, I would love to. If you're coming to CRT, maybe it's the first meeting, I would like to meet you.
Thank you. We'll be in touch. I'm not going to CRT, but we'll be in touch. Thank you. So
Okay.
Iman,
Thanks, guys.
Should we stop
No,
here
please
or?
go, please go on. I only have to jump because I have patience.
Yeah,
Thanks a
we're
lot.
still listening.
Bye-bye.
Okay. Right, maybe we can expedite things a little bit here. How much time should we leave for questions? 10 minutes, or what's your timing?
Yeah, we can have 10 minutes at the end. Like it should be 40 minutes plus. So
Okay, sounds good. So you still see the screen or it went away?
yeah, but it's not okay. It's good now.
Okay. So we were just talking how in this example, an AI algorithm using one input, which is the waveform, ideally you would want to bring all the inputs, right? The images, all the studies that you do for those patients, and almost come up with the new AS classification and prognostication rather than depending on the discrete value like a gradient or valve area or XYZ, right? So that's what AI can help us. It can bring all of those cardiac, extra cardiac parameters into a unified way to classify the valve and prognosticate the patient. And just an example of how many interactions the valve has with the different systems and how AI can help us if we feed the model with all of those data points. It's a task that a human can do, right? When we publish papers saying that the impact of COPD on TAVR outcomes, impact of GI bleed, this and that, right? But we don't put it all together, and that's what it's because we don't have the 100 eyes and we don't have the massive computer brain, right? If we leverage AI, then we're able to do that comprehensively. So just an example of an older paper. Also, I'm looking at phenotypic recognition of AS using machine learning by not looking at um, discrete factors, but allowing the AI to group patients based on outcomes and help us decide which ones have the more significant disease. I think I'm going to stop here. There are more things to talk about how to make AS interventions more precise. I was going to put a plug about some other technologies like CFDs, magnetocardiography, but maybe we can do that at another time and let's open it up for questions now.
Sure. So let me start with my question then. I don't know if the guys have any question, but my question was about AS. I don't know if that was the thing you were going to talk about. So since we're doing TAVR and the sizing and planning of this valve size is like the most important thing, and like avoiding complications and long-term outcomes. So is there like an algorithm to decide that? I know that each patient, as you said, is different. Each anatomy is different. Every time we look at a CT, it's different from one patient to another. So it's not like a population-based decision on sizing of the valve. So is there like an algorithm with AI that you could?
Yeah, it was part of the next chapter, which was, it's a trade-off, right? If you
Yeah.
size, I mean, if you oversize, we were told don't go aggressive because you'll cause dissections and stuff. But then when we didn't go aggressive, we had leaks. And then we said, like, okay, let's go more aggressive. They had more pacemakers. And they
Yeah.
were told, let's just go up higher in the annulus. And then we had no good coronary access, right? So it is a trade-off between different things. And that's what AI can do. I think the future will be everybody will get the simulated TAVR virtual digital twin of the patient. You do the TAVR in different places and you can come up with the best, not just sizing, but location and orientation of deployment. It's already there. The technology is already there, but it hasn't been packaged in that comprehensive fashion. Uh, but essentially, there is no reason to guess when we can actually see what will happen with different sizings and different implantation techniques.
Yeah. Thank you. Anybody has any other question?
Excellent talk, Dr. Alkhouli. Thank you. Yeah, I think you've put it very nicely that at present, I think the role is to kind of point us in the direction of where we should be looking. and kind of highlighting, that we might be missing things. So kind of like AI being a safety net, or
I
an
don't know.
early indicator.
Yeah, I don't know if it's safety net as much as it is use it as an augmented, just a tool, right? It's a
Hmm.
tool. It's not a safety net. It's actually it can be a danger net.
Yeah, so
But
that was my point, that some people may rely on it as a safety net, and that's the big worry, right? That you go, okay, the AI has said that it's not aortic stenosis, then we don't need to, go monitoring these patients or go looking harder for various things. So I guess there's that balance then of where human intuition still comes into play a lot, and I mean, I guess moving forward uh, in the realms of interventional cardiology, you've shown us some very nice examples of where AI is very useful. In the next 5 years, what do you think AI will be doing for us as interventional cardiologists?
yeah, I think one example we just mentioned, which is complete virtual deployment and simulation. We do it now sometimes with left atrial appendage if there is a complex anatomy. I think this should be just universal. There is no reason to attempt things in the human where we can do it all, optimize it all in the digital twin environment, right? So that's readily available. I think administratively or these decision support triage kind of things will be easy to do, like matching clinical trial, inclusion, exclusion, summarizing notes, all these kind of administrative things will become more and more embedded in clinics. We already have that. We have the ability to not actually write a note altogether. We have ambient listening that can write the note and you edit it and all of that now. Um, People have different views on that, but essentially you can see AI cutting down the cut work quite a bit in those administrative tasks. But the big question is, would it lead to groundbreaking new information or not? I mean, even driverless car, it's not new knowledge for humanity, right? It's just a tactical thing. It's a comfort thing. It's a convenience thing. But would AI be able to find out a mechanism that nobody had known before or humans couldn't find? That's the big question that people have different views on.
Thank you.
Okay.
If nobody has any question, we're going to be closing. Dr. Mohamad, thank you. This was a really, really insightful talk. You opened our eyes into not accepting everything as they are and re-questioning even the guidelines and what might go into that and out of it. So thank you so much for the talk. And if nobody has anything else to add, it was a pleasure having you here with us today. Then
Thank
I'll
you.
close the session.
Great to see you
Can
all.
I have
Yeah.
a single
Yes.
Thanks a lot.
question?
Somebody had a question.
Somebody had a question?
Yes,
Ahmed.
please. I'm sorry.
Yes, go
Yes.
ahead.
Thank you, Dr. Alkhouli, for the presentation. I was wondering, after all of this interrogation of AI and cardiology and a lot of other fields, do you see it as useful for physicians, for interventional cardiologists, to know how to create algorithms, just the math behind it, to know how to interrogate it, or just we can know that the engineers and AI engineers are available, we can drop them our insights and they develop algorithms for us?
Yeah, good question. I think it will be unless you're born coding or if you were coding making games when you were a kid, it's hard to get to a level of proficiency that you're going to be the primary person developing the algorithm. I think there are a few physicians who would fit that, but it's almost not very, it doesn't make a lot of sense to spend too many hours in the cath lab and too many hours in coding. You'll have to decide at some point, right? But I think what we have done here is we have our AI engineers actually next to the cath lab. So we talk to them a lot. We learn how to interpret the algorithms, the limitation of the algorithms. We have AI journal clubs, um, lots of interaction because they speak a different language, and there is a lot of benefit from having that mutual experience. So, like everything else, I think the more important thing is understanding the big picture, the philosophy, and the interpretation of the algorithm rather than doing the coding yourself.
Oh, okay, thank you very much.
Great. Thank you again, everyone, for being here. And thank you again, Dr. Mohamad, for being here with us.
All right, well, thank you very much. Take care, and it
you
was
too.
nice seeing you all.
Yeah, thank you. Bye-bye.